Hello and welcome to our presentation on hiatal hernias and GERD. This is Nikki, and me, Ellie, and Bella worked together to complete this. So for the objectives of this presentation, by the end of it, students will be able to understand the two different types of hernias, understand signs and symptoms of hiatal hernias, understand causes of hiatal hernias, understand how a hernia is diagnosed, understand treatments of hiatal hernias, understand what GERD is, understand what causes GERD, understand what factors can lead to GERD, know the signs and symptoms of GERD, understand how GERD is diagnosed, and understand how GERD is treated. Okay, and now I'm going to talk about what a hiatal hernia is. So anytime an internal body part pushes into an area where it doesn't belong, it is called a hernia. A hiatus is an opening in the diaphragm, the muscular wall separating the chest cavity from the abdomen. In a healthy person, the esophagus goes through the hiatus and attaches to the stomach. But when someone has a hiatal hernia, it's when the stomach bulges up through the chest through that opening. So next I'm going to talk about the different types of hiatal hernias, and there are two different primary types. The first one, or type 1, is called a sliding hiatal hernia, and in future slides we will cover what this entails. And there's also a picture on down to the right of the two different types. Letter A is a sliding hiatal hernia, and then the second type is a paraesophageal or rolling hernia, which is seen at letter B. You can kind of take a look at those to see how they differ from each other just from the visual aspect of them. Okay, and now I'm going to be showing a video on sliding hiatal hernias and just a brief overview of them.
This animation will show how a hiatus hernia forms. There are two types of hiatus hernia, sliding and rolling. This animation focuses on the more common type, a sliding hiatus hernia. Click the navigation arrows below the animation screen to play, pause, rewind, or fast forward the animation. Your esophagus, the pipe that goes from your mouth to your stomach, passes into your stomach through a hole or hiatus in your diaphragm. Normally, the stomach is situated completely below the diaphragm, as shown here. The esophageal sphincter acts like a one-way valve to stop the acid that's produced in your stomach to break down food from flowing up into your esophagus. Here, we show the valve opening and closing. In a sliding hiatus hernia, the sphincter and the top part of the stomach push upwards into the chest. A hiatus hernia can prevent the esophageal sphincter from closing properly. If this happens, acid from the stomach can pass into the esophagus and cause discomfort, known as heartburn. However, often hiatus hernias don't cause any symptoms. Sliding hiatus hernias are usually quite small. They can slide back and forth through the hiatus, so symptoms can come and go. Sometimes sliding and rolling hiatus hernias are present at the same time. This is known as a mixed hernia. This is the end of the animation. Click on the animation screen to watch it again.
So hopefully that video was helpful in understanding sliding hiatal hernias. Okay, and so now I'm going to dive into the first type of hiatal hernia, which is a sliding hiatal hernia. Um, and according to the textbook, it's when the junction of the stomach and esophagus is above the diaphragm and a part of the stomach slides through the hiatal opening in the diaphragm. This occurs when the patient is supine, and the hernia usually goes back into the abdominal cavity when the patient is standing upright. And as you saw in the video, these are hernias that can come and go, so symptoms tend to be on and off. And this is also the most common type, and it occurs in about 95% of the cases that patients present with. So the next type of hiatal hernia that I'm going to cover is the type 2 or paraesophageal rolling hernia. This one is not as common as a sliding hernia, but it is more dangerous. The paraesophageal hernia occurs when the GE junction is in normal position, but a portion of the stomach or the fundus has protruded through the hiatus and places pressure on the esophagus. And the word paraesophageal stands for next to the esophagus, so it goes on kind of on the side of the esophagus, as you can see in the picture on the right side. Okay, so paraesophageal hernias continued, or also known as rolling hernias. The majority of the people who present with hernias have a paraesophageal hernia, but are usually asymptomatic. And asymptomatic paraesophageal hernias should be observed, but they do not require surgery. But this changes when a paraesophageal hernia becomes symptomatic. So the person is experiencing something like chest pain or difficulty swallowing, upper abdominal pain. This is when it needs to be treated and repaired, and the person needs medical attention. If symptomatic, the patient is at greater risk for stomach getting stuck and causing obstruction, and the blood supply getting cut off from part of the stomach, also known as ischemia. If ischemia is present, the patient needs to be rushed into immediate surgery, as this is a serious medical problem and needs immediate attention. So now I am going to talk about sliding versus paraesophageal, or sliding versus rolling. Kind of going to distinguish the difference between the two. So in a sliding hernia, the gastroesophageal junction slides into the thoracic cavity, moving the esophagus and all of its contents upwards. In contrast, a paraesophageal or rolling hernia happens when the gastroesophageal junction, specifically the fundus of the stomach, has herniated through the hiatus and to the side of the esophagus. A paraesophageal hernia typically puts pressure on the esophagus, and you can see on the photo on the right side that the main difference is just that the sliding hernias go straight upwards, and the rolling or paraesophageal go to the side and kind of put pressure on the esophagus over there. And the paraesophageal is more serious when symptoms come on than the sliding, and the sliding is more common than paraesophageal. So now I'm going to talk about the signs and symptoms of hiatal hernias. And I say hiatal hernias because both of them, paraesophageal and sliding, typically present with the same signs and symptoms. And you'll also see when we cover GERD that these hernias also tend to be the same symptoms as GERD. but we'll cover that later. So the symptoms of the hernias that patients tend to present with are heartburn, regurgitation of foods and liquids back into the mouth, backflow of stomach acid into the esophagus, also known as acid reflux, difficulty swallowing, chest or abdominal pain, feeling full very soon after eating, shortness of breath, and finally vomiting of blood or passage of black stools, which indicated gastrointestinal bleeding. So, for causes of hiatal hernias, the cause is not clear. However, there is information that is known about them, and some of that information includes it is thought that most hiatal hernias develop in people over the age of 50. So, just something that comes on with age tends to happen in people that are older. And the diaphragm muscle weakens with age. Um, and then factors which increase the pressure in the abdomen and increase your risk for developing a hiatal hernia are chronic coughing, repeated lifting of heavy objects, obesity, pregnancy, ascites, tumors, intense physical exertion. And if you have had operations around the stomach and gullet, you are more likely to get the paraesophageal type of hiatal hernia. And then if your spine or rib cage is more curved than usual, you are at greater risk for getting a paraesophageal hernia. So these are people with conditions such as kyphosis or scoliosis. Kyphosis is where you kind of have like a hunchback, and scoliosis is just the typical like S curvature of the spine. Um, it's just curved a little bit. Okay, and now I'm going to talk about how hiatal hernias are diagnosed. They are usually diagnosed during procedures or tests that are being done to figure out why a patient is experiencing chest pain, acid reflux, or heartburn. So the first test is an esophagram or a barium swallow test, and it will show protrusion of gastric mucosa through esophageal hiatus. And the second is an x ray of the upper digestive system. The third is an upper endoscopy. And the fourth is esophageal manometry. So, now for treatments of hiatal hernias, along with diet and lifestyle changes such as avoiding triggering foods, surgical repair may be needed to reduce a hiatal hernia. These surgeries include reduction of herniated stomach into the abdomen, herniotomy, which is an incision of the hernia sac, um, and then a herniorrhaphy, which is closure of the hiatal defect, fundoplication, and a gastropexy, which is an attachment of the stomach below the diaphragm to prevent reherniation. And all of these surgeries are done laparoscopically, so a laparoscope is inserted through the abdomen instead of the chest, and they are able to make very small incisions to carry out and perform these surgeries to fix a hiatal hernia. So now I'm going to go into a hiatal hernia laparoscopic surgical repair process. So almost all of hiatal hernias can successfully and safely be repaired laparoscopically. This surgery, in this surgery, there's 5 very small incisions that are created by the surgeon, and they go through the abdomen rather than the chest cavity. The laparoscopic repair of large hiatal hernias, most of the stomach resides above the diaphragm and the chest cavity, It is a complex procedure and should only be attempted by expert laparoscopic surgeons with extensive experience in laparoscopic foregut surgery. During the surgery, the stomach is gradually moved back into the abdominal cavity where it belongs, and the diaphragm at the esophageal hiatus is closed to prevent the stomach from reherniating. In some cases, a special kind of mesh is needed to close the diaphragm appropriately. And once the diaphragm has been closed, most patients undergo a fundoplication or a wrap, similar to what is done for a patient with GERD. The fundoplication is performed to help keep the stomach from herniating back into the chest cavity. So overall, seems to be an effective way to treat these through laparoscopic surgery, which is a very patient-friendly way to have less incision area and scarring.
Okay, so now we're going to talk about some foods to avoid with a hiatal hernia and GERD. So these foods may cause the symptoms to increase, and these foods include citrus foods such as oranges, grapefruits, lemons, orange juice, grapefruit juice, cranberry juice, and lemonade, chocolate, fatty and fried foods such as fried chicken and fatty cuts of meat, garlic and onions, spicy food, peppermint and spearmint, tomato-based foods such as spaghetti sauce, pizza, chili, salsa, and tomato juice, coffee and tea, including decaffeinated tea as well, and coffee, and alcohol, carbonated beverages, dairy products such as whole milk, ice cream, creamed foods. You should try some soy milk. It may be a good milk substitute. And mild cheeses like feta or goat may be enjoyed in moderation. And then oil and butter can also cause the symptoms to increase. And next, we're going to take a look into GERD, but we mentioned that these are foods to avoid with hiatal hernia and GERD because they work hand in hand a lot of time, and a lot of things that affect hiatal hernia will affect GERD. Now we're going to take a look and see what GERD is. GERD is gastroesophageal reflux disorder, or people also refer to it as chronic acid reflux. It's a condition in which acid-containing contents in your stomach persistently leak back up into your esophagus, which is the tube from your throat to your stomach. Acid reflux happens because a valve at the end of your esophagus, the lower esophageal sphincter, doesn't close properly when food arrives at your stomach. So therefore, acid backwash flows back up through your esophagus into your throat and mouth, giving you a sour taste. So now I'm going to play this video that explains and talks about heartburn, acid reflux, and GERD.
When you swallow food, it travels through a tube called the esophagus. The esophagus leads into the stomach through a hole in a sheet of muscle called the diaphragm. There's a round muscle at the bottom of the esophagus that works like a valve. The muscle relaxes when you swallow, allowing food to pass into the stomach. Certain cells in your stomach, called proton pumps, release acid to help digest the food. The lining of your stomach protects it from the acid. The esophagus has a different type of lining, which looks like it's made of smooth tiles. The valve is designed to close tightly after you swallow, so nothing comes back into the esophagus. Your diaphragm is also meant to pinch securely around the esophagus, closing off the opening to your stomach. It's normal for a small amount of acid to occasionally splash into the esophagus. This is called reflux. That word means flowing back. A small amount of reflux doesn't usually cause any harm. But if acid splashes up into the esophagus over and over again for years, the esophagus can be damaged. There are several reasons this might happen. It's not uncommon for the valve to become weaker, so it doesn't close tightly. That allows acid and partially digested food to come up into the esophagus. Sometimes the diaphragm weakens around the esophagus, allowing the hole to become larger. This hole is called the hiatus. When it becomes larger, part of the stomach may bulge through it. This is called a hiatal hernia. The hernia may cause the esophagus and the valve to move up. In that case, the diaphragm is no longer reinforcing the valve. That makes it more likely that acid will get into the esophagus. When acid in food splash up into the esophagus repeatedly, it's called gastroesophageal reflux disease, or GERD. Gastro for the stomach, or gastric system. Esophageal for the esophagus. Mayo Clinic's Division of Gastroenterology and Hepatology is recognized as #1 by U.S. News and World Report. Go to mayoclinic.org to find out how to request an appointment with a Mayo Clinic physician.
Now we're going to look at the cause of GERD. GERD is caused by frequent acid reflux. When you swallow, a circular band of muscle around the bottom of your esophagus, which is called the lower esophageal sphincter, relaxes to allow food and liquid to flow into your stomach. Then the sphincter closes. If the sphincter relaxes abnormally or weakens, stomach acid can flow back up into your esophagus. This constant backwash of acid irritates the lining of your esophagus, often causing it to become inflamed. Now we're going to look at some factors that can lead to GERD. And as we know, GERD is also known as chronic acid reflux. And some factors that lead to acid reflux are too much pressure on the abdomen, and this explains why some pregnant women experience heartburn almost daily. And as we know, heartburn is one of the most common symptoms of GERD. And then particular types of food like spicy, dairy, or fried foods and their eating habits can lead to acid reflux. Medications that include medicines for asthma, high blood pressure, and allergies, as well as painkillers, sedatives, and antidepressants. And then lastly, a hiatal hernia can lead to acid reflux, and this is where the upper part of the stomach bulges into the diaphragm, getting in the way of normal intake of food. Now we're going to look at some risk factors for GERD. So some risk factors would be overweight or obese, if you're pregnant, smoking or regularly exposed to secondhand smoke, taking certain meds that may cause acid reflux, having conditions that weaken the esophageal muscles, such as scleroderma, have nervous system problems, and have a nasogastric tube. And this is because the tube passes through the lower esophageal sphincter. So we could think of anything that can weaken the lower esophageal sphincter will can always have the chance to cause GERD. Next up, I'm going to cover the symptoms of GERD. There are two main symptoms, which are persistent heartburn and acid regurgitation. These are the most common ones that you will see in a patient who's presenting with GERD. Some people may experience GERD without heartburn. Instead, they have pain in the chest or hoarseness in the morning or trouble swallowing. It may feel like there's food stuck in your throat, or feel like you are choking, or that your throat is very tight. And then some other symptoms that we will look at are coughing, chest pain, problems swallowing, vomiting, and sore throat and hoarseness. Okay, now we're just going to touch on infants and children's very briefly, because GERD can be seen in children as well, and they experience similar symptoms of GERD. And these symptoms are frequent small vomiting episodes, excessive crying, and not wanting to eat, especially in babies and infants, other respiratory/breathing difficulties, frequent sour taste of acid, especially when lying down, a hoarse throat, feeling of choking that may wake the child up, bad breath, and difficulty sleeping after eating, especially in infants. And treatments to be considered if my child has GERD. You want to get advice on avoiding triggers, over-the-counter medicines, prescription medicines, information on proper body positioning, like maintaining an upright position after eating meals or feedings. And then, as a very, very last resort, the same as with an adult, they'll look at surgery. Now we're going to look at the diagnosis of GERD. Many people experience acid reflux from time to time, which is normal. It can only be considered GERD when it becomes chronic. So if you have acid reflux or heartburn more than twice a week over a period of several weeks, if you constantly take heartburn medications and antacids, yet your symptoms keep returning, you may have developed GERD. Your GERD should be treated by your healthcare provider. Okay, and as we keep looking at the diagnosis of GERD, there are also some tests that can be done to determine if someone has GERD. The first test is an upper GI endoscopy and biopsy. This is when your provider feeds an endoscope, which is a long tube with a light attached, through your mouth and throat to look at the lining of your upper GI tract, which is your esophagus and stomach and duodenum. The provider also cuts out a small bit of tissue, biopsy, to examine for GERD or other problems. The next test is an upper GI series. This is when x-rays of your upper GI tract show any problems related to GERD. You drink barium, a liquid that moves through your tract as the x-ray tech takes pictures. The next test is an esophageal pH and impedance monitoring and Bravo wireless esophageal pH monitoring. These tests both measure the pH levels in your esophagus. Your provider inserts a thin tube through your nose or mouth into your stomach. Then you are sent home with a monitor that measures and records your pH as you go about your normal eating and sleeping. You'll wear the esophageal pH and impedance monitor for 24 hours while the Bravo system is worn for 48 hours. Next, we'll look at the esophageal manometry. A manometry tests the functionality of lower esophageal sphincter and esophageal muscles to move food normally from the esophagus to the stomach. Your provider inserts a small flexible tube with sensors into your nose. These sensors measure the strength of your sphincter, muscles, and spasms as you swallow. Okay, now we're going to look at the treatments of GERD. There are many treatment options that you can look at, and the first one and the least invasive one is lifestyle changes. These lifestyle changes include weight loss, elevating the head of the bed, stopping smoking and stop frequent alcohol use, avoidance of meals 2 to 3 hours before bedtime, reduce your intake of coffee, chocolate, spices, acidic foods, and high-fat foods. And then if these don't help with your GERD, then we'll look at over-the-counter medicines that are available, like antacids, which provide quick relief by neutralizing stomach acids, which are Tums, Rolaids, Mylanta, Riopan, and Malox. And then you can look at H2 receptor blockers, which decrease acid production. And then we'll look at the proton pump inhibitors, which are stronger acid blockers that also help heal damaged esophagus tissue. And then baclofen is a prescription drug used to reduce the relaxation of the lower esophageal sphincter, which allows acid backwash. Okay, and then we're going to keep looking into the treatment of GERD, and if the over-the-counter medications don't work and the lifestyle changes do not work, you can look at a little bit of a more invasive procedure, which is the laparoscopic anti-reflux surgery. This is the most common surgery used to treat GERD. It's a minimally invasive procedure that fixes your acid reflux by creating a new valve mechanism at the bottom of your esophagus. The surgeon wraps the upper part of the stomach, which is the fundus, around the lower portion of the esophagus. This reinforces the lower esophageal sphincter so food won't reflux back into the esophagus. And then another surgical option is the LINX device implantation, which I think is really interesting. A LINX device is a ring of tiny magnets that are strong enough to keep the junction between the stomach and the esophagus closed to refluxing acid, but weak enough to allow food to pass through.
Okay, so here's our case study. So Mrs. Kelly, a 78-year-old female with a BMI of 32, presents to the doctor's office complaining of a frequent burning sensation in her chest, usually made worse after eating spicy foods and when trying to sleep at night. The patient states, "I smoke a pack of cigarettes a day and drink a few glasses of wine with my dinner every night." The patient has noted that the burning in her chest happens every night and that she cannot manage her symptoms anymore. She reports that laying down to sleep makes the burning sensations in her chest and throat more severe. Okay, so our patient's diagnosis that we have for Mrs. Kelly is GERD, gastroesophageal reflux disorder. She's displaying most of the cardinal signs and symptoms, like the pain in her chest and the burning sensation, how it gets worse after she eats spicy food, and how it gets worse when she sleeps at night. And also, especially because she's been diagnosed with a hiatal hernia, GERD usually always follows that. So we have two nursing diagnoses for our patient. Our first diagnosis is acute pain related to GERD. And some of the patient goals that we're going to make for our patient is that she will report pain is relieved. She will ingest daily nutritional requirements in accordance to activity level and metabolic needs. And this is because obesity worsens GERD, and she has a BMI level of 32. So we want to get her on a good diet so that she can lose some weight and hopefully alleviate her symptoms. The patient will maintain a patent and clear airway. The patient will have increased knowledge of actions that reduce reflux. And then some nursing interventions that we can do as nurses. We would want to obtain a nutritional history of our patient, instruct her to remain in an upright position at least 2 hours after eating every meal, and then avoid eating meals for at least 3 hours before bedtime so we don't get that acid reflux back into the esophagus when she lays down at night. And then we want to encourage her to eat small, frequent meals of high calories and high protein foods, because when you eat small, frequent meals, it's easier to digest, so we won't get as much of that acid reflux. Okay, and then our second of two nursing diagnoses is deficient knowledge related to and regarding the condition and disease process. So our patient is deficient in her knowledge of GERD, so we're going to explain that to her. Some patient goals. The patient will understand and follow provided suggestions regarding GERD, such as avoiding spicy foods and medication compliance. The patient will be sufficiently informed of treatment and medication options. And then some nursing interventions that we as nurses can do. We want to provide our patient with information regarding the disease process, health practices that can be changed, and medications to be utilized. We want to instruct our patient to avoid temperature extremes of food, so no super hot foods or super cold foods, no spicy foods or citrus, and no gas-forming foods, because these will all heighten the side effects of GERD. And then we want to instruct our patient regarding avoidance of alcohol, smoking, and caffeinated beverages, which all worsen GERD. And we want to instruct our patient in medications, effects, side effects, and to report to the physician if any of her symptoms persist despite her medication treatment. So if she's taking the medications and her symptoms aren't getting any better, then we want her to consult her physician. Our case study resolution for Mrs. Kelly is the following. Mrs. Kelly was diagnosed with GERD. The doctor recommended that Mrs. Kelly make lifestyle modifications such as losing weight, eating earlier in the day, sleeping in an upright position, quitting smoking, and drinking less alcohol or avoiding it altogether. And if she does all these things, then her symptoms of GERD will be less extreme and less severe and less painful. The doctor also educated Mrs. Kelly about how these behaviors may affect GERD. So if she continues these poor behaviors, then her GERD will get worse. The doctor also prescribed Mrs. Kelly an acid reduction medication, which will hopefully alleviate her symptoms and cause less acid reflux into her esophagus. So some key points and takeaways from our presentation. First, a hiatal hernia is when the stomach bulges through the hiatus and pushes on the esophagus. And there are two types of hiatal hernias. The first one is a sliding hernia, and that's when the stomach pushes through the hiatus and kind of just pushes the esophagus up. And then the paraesophageal or rolling hernia, that's when it's the same thing, the stomach pushes through the hiatus, but it kind of pops out to the side of the esophagus, and usually that places pressure actually on the outside of the esophagus. And then hiatal hernias cause the stomach acid to come up into the esophagus, resulting in GERD. So the acidic contents of the stomach kind of regurgitate up into the esophagus, and it'll burn your esophagus, and that's why in our case study, Mrs. Kelly got that burning sensation in her chest and her throat, and that is called GERD, and then which is gastroesophageal reflux disorder. And then a few causes of hiatal hernias and some risk factors include obesity, pregnancy, constant heavy weightlifting, and intra-abdominal pressure, which usually comes with obesity, or like ascites, all that pressure in the stomach. And then GERD is also known as chronic acid reflux. GERD occurs when the lower esophageal sphincter weakens and the stomach acid flows back up into your esophagus, and it burns it. And then the main symptoms of GERD include persistent heartburn and acid regurgitation, or acid reflux. Okay, so now we have some NCLEX style questions for you guys. So I'll just read the questions and I'll read through the answers, and then I'll give you guys a second to think about your answer and guess your answer, and then I'll read the answer in the next slide. So our first NCLEX question is, the nurse explains to the patient with gastroesophageal reflux disorder that this disorder, A, results in acid erosion and ulceration of the esophagus caused by frequent vomiting, B, will require surgical wrapping or repair of the pyloric sphincter to control the symptoms, C is the protrusion of a portion of the stomach into the esophagus through an opening in the diaphragm, or D involves relaxation of the lower esophageal sphincter, allowing stomach contents to back up into the esophagus. So I'll let you guys take a second to think about your answer. Alright, so the answer for our NCLEX style question number 1 is D. It often involves relaxation of the lower esophageal sphincter, allowing stomach contents to back up into the esophagus. So this is the answer, and an explanation for it is the acidic contents of the stomach touching the inside of the esophagus are responsible for the physical sensation known as heartburn. And that's when the acid comes back up into the esophagus and it causes that burning sensation. That's what heartburn is. And this is a cardinal symptom of GERD. Okay, and our NCLEX question number 2. During a home health visit, you are helping a patient develop a list of foods they should avoid due to GERD. Which items in the patient's pantry should be avoided? In this question is select all that apply, so there should be multiple answers. So it could be A, hot and spicy pork rinds, B, peppermint patties, C, green beans, D, tomato soup, E, chocolate fondue, F, almonds, or G, oranges. So I'll let you guys take a second to think about that. Alright, so our answer for number 2 is A, B, D, E, and G. So that would be A was hot and spicy pork rinds. So with GERD, you want to avoid all spicy foods because that's going to really flare up the acid reflux. B, peppermint patties. Kind of the same thing, not that they're spicy in the same way, but they're very minty. So that's going to flare up your acid reflux as well. Tomato soup was D. Tomatoes are very acidic, so that's just adding more acid. E was chocolate fondue, so it's recommended that you avoid chocolate if you have GERD. And then G was oranges, which same thing as tomato soup. Oranges are very acidic, so that's just adding acid to an already very acidic environment. So you want to avoid all those foods to help alleviate your symptoms of GERD. And if you eat them, then that's probably going to make your symptoms worse and cause you to have more heartburn and that burning sensation in your throat. Okay, and then our third NCLEX question is, the nurse is obtaining a health history from a client who has a sliding hiatal hernia associated with reflux. The nurse should ask the client about the presence of which of the following symptoms? Is it 1, heartburn, 2, jaundice, 3, anorexia, or 4, stomatitis? So really think about what are the cardinal signs of you would be thinking about GERD, because there's a hiatal hernia here, and usually GERD follows the hiatal hernias. So I'll give you guys a second to think about that. Okay, and then the answer for that third question was 1, heartburn. And like I said in the slide before, this is because the patient has GERD. So although it didn't say she was diagnosed with GERD, if you have a hiatal hernia and any symptoms of GERD, any burning sensations in the chest or throat, you can likely believe that that patient has GERD. So heartburn is the most common symptom of a sliding hiatal hernia, and it results from reflux of gastric secretions into the esophagus. Regurgitation of gastric contents and dysphagia are other common symptoms. Jaundice, which results from a high concentration of bilirubin in the blood, is not associated with a hiatal hernia, so that's why the answer is not jaundice. Anorexia is not a typical symptom of a hiatal hernia either. Stomatitis is inflammation of the mouth. So those are why heartburn is the answer and all those other answers are wrong. So our fourth NCLEX question, I'll read it out to you. The client asks the nurse whether he will need surgery to correct his hiatal hernia. Which reply by the nurse would be most accurate? Number 1, surgery is usually required, although medical treatment is attempted first. Number 2, hiatal hernia symptoms can usually be successfully managed with diet modifications, medications, and lifestyle changes. Number 3, surgery is not performed for this type of hernia. And number 4, a minor surgical procedure to reduce the size of the diaphragmatic opening will probably be planned. So think about those, and I'll give you a second to get your answer ready. Okay, and then the correct answer for number 4 was number 2, which is a hiatal hernia symptoms can usually be successfully managed with diet modifications, medications, and lifestyle changes. So, like you saw in the earlier slides, there are surgeries for hiatal hernias. Usually, you would not have surgery for hiatal hernias that are asymptomatic. But if they get more severe and your symptoms become intolerable, then there's multiple surgeries that can be done, usually laparoscopically, that can fix the hernia. So most clients can be treated successfully with a combination of diet restrictions, so getting your weight back in check, eating healthy, avoiding foods that increase your symptoms of GERD, being on the right medications, weight control, and lifestyle modifications. Surgery to correct a hiatal hernia, which commonly produces complications, is performed only when the medical therapy fails to control the patient's symptoms. So it's only when your symptoms get so severe and all these lifestyle changes and medications have not been working, that's the only time when usually a doctor is going to recommend that you get surgery to fix your hiatal hernia. All right, and then our last NCLEX question is number 5. The home health nurse is caring for a male client diagnosed with a hiatal hernia and reflux. Which data indicates the medication therapy is effective? Is it 1, the client takes the antacid 1 hour before and 3 hours after a meal? 2, the client reports indigestion after eating a large meal? 3, the client states that he did not wake up with heartburn during the night? Or 4, the client has lost 3 pounds in the last 2 weeks? So I'll give you a second to think about your answers, and then we'll go to the next slide. Okay, so our last answer for this last NCLEX question was answer number 3, and that was the client states that he did not wake up with heartburn during the night. So this indicates an improvement in symptoms and that the medication is effective, because people with a hiatal hernia and GERD usually always experience acid reflux and heartburn at night when they're laying down. So the fact that this patient is not experiencing that anymore and isn't waking up in the middle of the night with heartburn, that's a big improvement, and that's an indicator that the medication is working. Okay, so that concludes our PowerPoint on hiatal hernias. Here are some of our resources, just websites that we got our information from. There's also the textbook is on the next slide. So these are just all of our resources that we got our information from. Okay, this is our last slide of resources. So our PowerPoint is finished. We really hope you guys enjoyed our PowerPoint and that you learned a lot about hiatal hernias, and thank you so much for listening and watching.